One of the reasons we really love to do Scan FYI is it's an opportunity for us to introduce you, our viewers, to different kinds of doctors and different services and resources in the community. Well, today we're all going to learn something because my guest today is a sports medicine physician. And you know what? I don't really know what that is. And I bet a lot of you listening, you don't know either. I mean, do we have to play tennis? Do we have to play football? What's the deal with this? Well, we're going to find out. So if you want to know more, stay tuned. Hey, good morning, everyone, and welcome to Scan FYI. Yeah, we have a different kind of physician with us today. We have Dr. Zachary Perlman. Good morning, and thanks for being my guest.
Good morning, Andrea. How are you today?
I'm doing really well. And you know what, Dr. Perlman? Let's not keep them in suspense any longer. Tell us, so what do we mean by a sports medicine physician? Introduce yourself.
All right, my name is Zach Perlman. I'm a sports medicine physician. Um, so I'm so I think of life as a sport. You know, you can play tennis, you can play soccer. I mean, that's of course a sport. However, as we age, you don't have to necessarily do that. I feel everything just moving around can be a sport. So if you enjoy taking walks, you like to go on the boardwalk, you like to go to the beach, or even just walk around the complex, you're activating muscles, and you get enjoyment out of that. So I feel that is also a sport. But a sports medicine physician is essentially a non-operative orthopedist. So the orthopedics is the study of the bones. Um, Not everyone knows this, but approximately 80% of orthopedics is not operative or non-operative. So I feel I'm an expert in that field.
In the
Um, it,
non-operative portion.
yes, in the non-operative portion of orthopedics. Um, Typically a patient will get injured, they hurt their shoulder. We hear a lot of like rotator cuff complaints. And you kind of rush and you call who's the nearest orthopedist, call the
Right.
orthopedist. um I have a lot of patients that come here. I mean, I'm not saying it's wrong to go see an orthopedist first, but the orthopedist is an expert in fixing it if it requires surgery. If it's partially torn, I have many options of the way that I heal the tear that don't require surgery. That's one of the benefits of coming to me as opposed to going to an orthopedic surgeon.
All right,
Is
it really does make sense. And I'm thinking just about everybody out there has been to an orthopedist for something, knees, hips, shoulders, you name it. And I have to agree, I think that's our typically oh, call the orthopedist, right? That's our first, because I think people don't know that there might be this other option. That's important. That's important, especially if you're not going, you might have hurt your knee, but you're not having a knee replacement. Maybe there is another approach for you, right? That would make sense. So it really
yes,
is the game of
correct.
life, the game of life.
Yes.
And it can be dangerous. We fall, we
Yeah.
get hurt, all of that, right?
Yeah, I mean, and as we age, we get these degenerative conditions. Of
Yep.
course, we hear I have arthritis. Arthritis is very, very common. Um, it's and also you hear also for the knees, you hear about meniscus tears. 50 to 60% of patients over 50 years old have meniscus tears. They don't all know it. And another thing I hear a lot is, oh, I have a meniscus tear. I have to get surgery on my meniscus tear. But that's not always true. Is not all
Yeah.
meniscus tears need surgery because the meniscus degenerates, and essentially is part of osteoarthritis. So that's another thing that I feel I'm an expert in is treating osteoarthritis and meniscus tears in the knee, and some other conditions
So
as
what are
well.
some of the, I'll call them non-operative procedures, if that's the right way to phrase it,
Yeah.
that you might offer someone who has an issue with whether it's arthritis or a knee, we're not having surgery, so what are we going to have?
Yeah, I think of it as like a spectrum. So over here on the
Yeah,
left is like most conservative, over here on the right is most aggressive.
like
So
surgery
here,
would be most aggressive.
yes, surgery
Okay.
would be most aggressive. So the surgery is the one thing I don't do. But over here, we could start with just basic things with oral medications, so anti-inflammatories, naproxen, and I know there's over the counter, and then there's also prescription strength. So I guide the patient on what to take at what dose, keeping in mind comorbidities such as kidney failure and diabetes and things like that. And so least aggressive here is like the oral medications. Then there's other medications such as the pain relievers and some other medications for calming down the nerves, such as
Okay.
gabapentin or Lyrica. Then there's home exercises. So the home exercises I can start discussing in the office. I have handouts that I can give. I can review the exercises with the patient. Then a little more aggressive would be going in to see a physical therapist. Going into, I don't provide it with my office, but I can write a prescription for it. And the
Yeah.
prescription will be specific for the patient's condition. And then next are the modalities that I offer in the office, such as injections. So a lot of them are injections.
Mm-hmm.
There's different things that I can inject, and it depends on what the problem is. If we're talking about the knee, we're talking about osteoarthritis of the knee, depending on what the symptoms are. If it's very swollen, I can drain the knee. So I use an ultrasound machine so I can monitor exactly where the needle's going. I numb the skin. I can pull out the fluid from the knee. I can send it to the lab and get it tested for like Lyme disease. I can check for crystals like such as gout or pseudo gout. I can check it for infection. And then I typically put back in there a corticosteroid. So people know it as cortisone. The
Yeah.
reason I'm doing the hand quotes is because most patients come in and say, "Hey, you're going to give me a cortisone shot," and I say yes. However, I like to educate, and cortisone isn't made in liquid form. It's just an easier way to say cortisone, but what you're getting
Okay.
is really a corticosteroid. Cortisone's easier to say than corticosteroid because the chemical that's being injected is not actually cortisone. The one I like to use is called triamcinolone. They also make beta-methazone. There's a few other types of corticosteroids that I use. That's usually standard, is that I start with, if it's a swollen knee, I drain the knee. I put back in a corticosteroid, and I'm very mindful if the patient has diabetes because corticosteroids can raise blood sugars. And then I usually order some imaging and then have a follow-up. But if the knee is not really swollen and it's just painful and achy, and the patient has contraindications to getting a steroid, so they don't like steroids or it makes them feel strange or they have
Yeah.
high blood sugar, then I do hyaluronic acid injections. The hyaluronic acid injections, also known as viscosupplementation, because you're supplementing the knee with a viscous ingredient, and it's also known as people call them gel shots as well.
Oh, yeah.
Um,
Okay.
yeah,
I'm familiar with that term,
yeah,
gel
yeah,
shots. Sounds
gel
like
shots.
Jello shots there, but yes, it's gel shots.
Yeah,
Yes, yes.
yeah. And I've also heard patients refer to it as rooster comb injections.
Yes,
Uh,
yes.
it depends, not all of it is made from the bird. Some are made are non-avian products. So, I use a few different brands. Medicare, it's FDA approved, so Medicare covers it without authorization. I think it's a great product, but it's only covered through insurance for the knees. I also use it for shoulder arthritis. I also use it for hip arthritis, and I've used it for a few other indications. With success, patients have felt better from it. Standardly, it's for the knee. So on any given day, I typically will inject like 3 or 4 patients' knees for osteoarthritis with this hyaluronic acid injection.
Well,
So,
Dr. Perlman, what are some, so for people listening And, I feel like everybody has a knee or a hip issue if you get to be over 50, maybe over 60. But what are some very typical symptoms that might drive someone to come see you, a sports medicine physician, before that jerk reaction of like, oh, let's
Yeah.
call the orthopedist. So, what are
Mhm.
some good reasons that we should reach out to you?
Yeah, so if you have new onset like stiffness or from prolonged sitting, if you have some stiffness or difficulty going up and down the stairs,
Mhm.
generalized weakness or generalized pain without knowing what the cause is, those are the main some of the main symptoms. Um, a lot of my patients do come through my door because they're seeing a physical therapist first. So they see the physical therapist and the patient doesn't necessarily want surgery. And I don't think anyone necessarily prefers getting a surgery if it's
Yeah.
not required or if there's other options because of the outcomes that I have in the office, then the physical therapist will send the patient to me. I'm comfortable really treating anyone that has pain or discomfort or stiffness, inability to do something that they're one of their daily activities. Another example would be if someone has difficulty like reaching behind their back or reaching overhead. I see it with females if it's hard to kind of clip the bra strap on and off or even like washing their back. And then after evaluating them, I determine that they have frozen shoulder. So that's another common complaint that I see here.
So do you ever have someone come in and you realize your conclusion is, you know what, they do need surgery, and then obviously you are going to refer them to an actual a surgeon.
Yes, yes, yeah. So I'm also an expert in determine like reviewing the imaging, so I look at pictures myself. So if I order
Yeah.
an X-ray or MRI and I determine that the patient has a surgical indication, then at that point I would send them to a surgeon. And I have a few on my, in my on my cell phone that I'll, communicate with if I see something and I'll say, hey, can you see this patient quickly? When they have a surgical indication, it usually, if they call the doctor's office, the orthopedic office, sometimes they wait weeks to be seen. When
I
I
see.
determine that they have a surgical indication, I can text, my colleague, coordinate to get the patient in sooner.
Well, that
For
is a very good thing, by the way.
Yeah.
So for if you're just tuning in, we're speaking to Dr. Zach Perlman. He is a sports medicine physician in Little Silver. Of course, all of his info will be in the show notes and whatnot. But I'm looking at some of the notes that you had sent to me, and so it looks like you do a lot of work with people with osteoarthritis, which
Yes.
is extremely common in older adults. So what do you want to tell people about that?
Okay.
Again, typically, let's go to the orthopedist, and you're not going to have surgery for that.
Yeah, so you don't necessarily have to get surgery. So osteoarthritis, so when you think of just the general term of arthritis, there's two big, buckets of arthritis. One would be inflammatory arthritis, such as rheumatoid arthritis, and then there's
Right.
osteoarthritis, which is more of what I'm an expert in. The rheumatoid arthritis is inflammatory. You wake up, you're swollen, and then you determine that you eventually will see a rheumatologist who will work you up and may put you on some medications to help the inflammation. Osteoarthritis, on the other hand, is more of a degenerative arthritis. Between the bones, you have cartilage. So there's
Mhm.
articular cartilage, which is on the surface of the bones, and there's a genetic component, but it's also a biomechanical component that over time, our joints just essentially break down. So the cartilage surfaces rub up against each other
Right.
and it starts to wear. And
The
then,
bone on bone thing
yeah,
that everyone
yeah.
talks about, right?
But recent literature has actually shown that osteoarthritis is also inflammatory. There's a low level of chronic inflammation that occurs. So although it's degenerative and that the joints break down, there's also some inflammation that occurs with it. I treat a lot of the arthritis. One instance is, say you have a car accident or some terrible trauma, you can develop post-traumatic arthritis.
Mm-hmm.
I'm thinking of a case where someone was in a car accident, fractured or broke his ankle, his right ankle, and then 20 years later came to me for left hip pain, and his left hip was not not in good shape. It was completely bone on bone. I did what I could for him. He ended up needing a hip replacement. I'm bringing up this case because, if you fracture one side of your body, it can change your biomechanics and you can walk and favor the left side. So this gentleman fractured his right foot and then was walking uh, in a strange, with a strange biomechanical pattern. So he wore out his left hip over time. So I also see that occurring, from time to time.
So very,
Yeah,
very, let me just say, very interesting. I had an injury to my knee when I was 16 years old, oddly enough, playing tennis. And we didn't realize how bad it was, but my gait was off. And over time, I wore out my right hip from having my gait off, and there was a hip replacement. Yeah.
yeah,
It's
that
funny how an injury can lead to this, but I certainly didn't know that sports medicine physicians existed. And I just think of all the things that the older adults, me, and all the people that I work with, the first thing you hear is, "Oh, I got to make an appointment at at the orthopedist." But
yeah,
you know
yeah.
what? Maybe you don't. Maybe you need to see Dr. Perlman.
And some other things, when we were talking previously about the non-operative treatments that I
Yeah.
perform that separate me from the orthopedist, I always use an ultrasound machine if I'm doing an injection. So no matter where I inject, I use an ultrasound machine, so I see on the screen where the needle's going and where the injection will be deposited. Not only do I inject the joints, which I talked about earlier, I do tendon injections. So I do an injection called a tendon sheath injection, which the tendon sheath is I think of it as like a sock around the tendon. So
Okay.
if someone has a rotator cuff pain and it's indicated, I will use the ultrasound machine. I can find that rotator cuff tendon and I can make sure that the medication is exactly outside of the tendon underneath the sheath. And then I take pictures on the ultrasound. Whereas if you didn't have an ultrasound machine, old school doctors or a lot of the orthopedics will do landmark based injections. So they'll like put their finger on your shoulder and measure 1 centimeter this way, 1 centimeter this way, and then just go and inject. And I find the outcomes are much better when you use the image guidance.
You're
So
working with absolute precision when you're using the
yeah.
ultrasound.
And some of the other procedures I do nerve blocks. So if someone has, for instance, sciatica, pain down the leg,
Right.
and
Very common, very common.
very common. Yeah. I do not do epidural injections, which a lot of patients have for the sciatica. So if a patient has has sciatica and they have had not good success with epidurals, I can do a sciatic nerve block. So I also can visualize the sciatic nerve on the ultrasound, and then I can deposit the lidocaine, the saline, possibly with some steroid at the level of the sciatic nerve very carefully. So those are some other procedures that I perform. And I always like to say too, an orthopedist at the end of the day, their training is in the surgery, is in operating and operating and operating. My training is in all the other things like these injections. So which is why I feel some of the outcomes may be better getting it under the ultrasound and getting the injections with me as opposed to getting an injection from the orthopedic surgeon who's really in the operating room all the time,
Right.
probably not injecting as much as I am. I also offer some other modalities. Well, one of them is for chronic knee pain. So if someone, even if they've had a total knee replacement already and they're having stiffness or discomfort in that knee, I do this procedure called iovera. That's the company, or actually the company is called Pacira, but iovera is the device that I use, and the term is called, it's a fancy term, it's called cryoneurolysis. It's a procedure where I freeze the nerves. I freeze these nerves, they're called genicular nerves. So because genicula comes from the Latin word for knee, which is genicula. There's four genicular nerves. I can freeze those nerves, and then it blocks the pain signal to the brain
Okay.
for up to 3 months. So I do a lot of pain management techniques in addition to practicing sports medicine.
So, doctor, your office is on White Street in Little Silver, And again, we're
Yep.
going to put all Dr. Perlman's contact info up there. I think that this was, for me, very educational. I didn't know anything about this, and I'm guessing to my listeners, you probably didn't either. And I think this makes a very good option. And I also want to mention that this Thursday we're having a lunch and learn. SCAN is having a lunch and learn, and Dr. Perlman will actually be there. So you know what? If you're coming to the lunch and learn, you will have the opportunity to meet and greet him in person. Show him your shoulder and show him your knee.
Yeah.
Well, thank you so much for being my guest today, Dr. Perlman. Really, very educational, enlightening. Thank you.
Yeah. Thank you for having me, Andrea.
So remember out there, if it's important to you, it's important to us. I'm Andrea Tarr, and we'll see you next time on Scan FYI. Bye, everyone, and bye, Dr. Perlman.
All right. Bye, Andrea.